Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die junge DGFN, die Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse Transplantation, Marcus at Home welcomes Professor Ary Serpa Neto in Melbourne, Australia, and Professor Boris Jung in Montpellier, France, with whom we would like to discuss the SODa-BIC trial on sodium bicarbonate treatment in critical ill adults with metabolic acidosis and shock, which has been recently published in the New England Journal of Medicine.
Dr. Ary Serpa Neto is Associate Professor, Intensivist, and Director of Intensive Care Research at Austin Hospital, Australia, and Co-Deputy Director at the ANZIC Intensive Care Research Center, ANZIC-RC, at the Department of Epidemiology and Preventive Medicine at Monash University in Melbourne, Australia. Dr. Boris Jung is Professor of Critical Care Medicine, Chair of the Medical Intensive Care Unit of the Hôpital Lapeyronie at the Centre Hospitalier Universitaire de Montpellier in Montpellier, France. He is Principal Investigator of BICAR-ICU and BICAR-ICU 2, which similarly to SODa-BIC also tested bicarbonate in critically ill patients with severe metabolic acidemia. Dear Ary, dear Boris, it's a pleasure to host you.
Thank you very much. So thank you very much for the invitation, and thank you very much for the opportunity to present the SODa-BIC trial here. And thank you, Boris, to join and discuss the trial with us. I think would be amazing. So I just want to start with some quick acknowledgements. I think it's important to acknowledge people who really helped with this trial. So this trial was funded by the NHMRC, which is our national funding agency in Australia. It was sponsored by the Australian New Zealand Intensive Care Research Centre, the ANZIC-RC, which was also the method center for this trial. And it was endorsed by the Australian New Zealand Intensive Care Society Clinical Trials Group. Of course, it's important to acknowledge all the families, patients, doctors, nurses, and allied health professionals who really helped with this trial. Important to mention that I'm presenting this on behalf of a big team. This is our management and our writing committee who did like a great job helping with the trial. And most importantly, also to acknowledge our project manager, Mairead, and our project officer, Fiona, who helped a lot with the trial. They did the hard work running the trial with me. We had also a DSMB that I want to acknowledge, led by Professor John Kellum from Pittsburgh, with the participation of Ming Shala from San Diego, and Anne is a statistician from Melbourne. And of course, the 55 sites involved in the study. So we enrolled patients in 55 sites in 7 different countries, in Australia, in New Zealand, in Japan, in India, Oman, Saudi Arabia, and Brazil. So again, thank you very much for all these sites who really helped us during this study. So this is my agenda. I would like to start briefly discussing the rationale for the trial, and then we will discuss the trial into a lot of details. So what is the importance of metabolic acidosis? I think we all know that metabolic acidosis is a prevalent and important condition in the ICU. Of course, the prevalence or the incidence varies with the type of definition and the type of severity that we investigate. I'm just showing here 2 different criteria. One is the BICAR-ICU criteria, and one is the SODa-BIC criteria, just to present the prevalence and the outcomes for these patients in Australia and New Zealand. So this is a study that we did years ago using data from a binational registry here in Australia and New Zealand. And we found that in the first 24 hours, and of course, this is only the first 24 hours because we have data only for the first 24 hours. But I understand that if we follow these patients through the whole ICU stay, of course, these numbers will be higher. But we found that in the first 24 hours of presentation in ICUs in Australia and New Zealand, the prevalence of the severe acidemia using the BICAR-ICU criteria was 1.5%, and the SODa-BIC criteria was 8.4%. The use of renal replacement therapy was 40% in patients presenting with severe acidemia and 26% in patients presenting with more moderate acidemia. And the mortality was 48% in patients with more severe acidemia and close to 22% in patients with less severe acidemia. So it is a condition that, depending on the definition, is relatively frequent in the ICU. Only in the first 24 hours, we can see that 10% of the patients met criteria for SODa-BIC. And it's still even when the acidosis is mild, mortality was around 22%, and 25, 26% of the patients needed renal replacement therapy. One thing that I really like to mention, and it was one of the rationales for us to design SODa-BIC, is that this is a very nice data from Boris, uh, suggesting that in this first study that they did, this observational study published years ago, like the severity of the acidemia at the baseline was not associated with bad outcomes. However, the persistence of the acidosis was associated with worse outcomes, suggesting that if we are able to avoid the persistence or the deterioration of the acidosis early, we might improve patient outcomes. So overall, the literature suggests that metabolic acidosis is relatively common in ICU patients, and that even mild to moderate metabolic acidosis is associated with poor outcomes. In Australia and New Zealand, 20 to 25% of mortality, which is similar to septic shock, of course, with a huge overlap of these populations, because a lot of patients with septic shock, they also present with metabolic acidosis and acidemia. And some data that we have in the literature suggests that if we treat the acidosis very early and we avoid persistence and deterioration, we might improve patient outcomes. About the use of sodium bicarbonate, we all know that the treatment of the metabolic acidosis and acidemia is the treatment of the underlying condition leading to it. But very often we use buffer solutions to treat the acidosis and to correct the acidemia. The most common one is sodium bicarbonate. And we do that first because of the immediate buffer effect of the bicarbonate per se. We also have some volume expansion and some mild hypernatremia induced by the use of sodium bicarbonate, which increases the intravascular volume and help resuscitation of these patients. However, on the other hand, the use of sodium bicarbonate is associated with an increase in CO2 production, and it might be associated with a intracellular acidosis, which of course this is debatable. A lot of physiological studies, they debate if the intracellular acidosis is something that it's really problematic in our patient, but there is the risk of having like a drop in intracellular pH with the use of sodium bicarbonate. But a lot of studies suggest that the speed that you infuse the bicarbonate might play a role in the risk of intracellular acidosis. So this is just one study in dogs. I highlighted here the most important forms of infusion. You can see here that the circle here is the continuous infusion, while the triangle here is the bolus infusion. You can see a continuous infusion was associated with a more steady increase in pH, while the bolus infusion was associated with an increase and then a drop. And about the PCO2 production, you can see that the bolus infusion was associated with an increase in CO2 and then a drop, while the continuous infusion was not associated with an increase in CO2, suggesting that a continuous infusion might reduce the risk of increase in CO2 and potentially intracellular acidosis. About the use of bicarbonate in real life, this is again a study from Boris. So this is in patients with severe acidemia with a pH less than 7.20. In this study, around 40% of the patients received one dose of sodium bicarbonate. Important to mention that I think this is the most important finding, is that the use varied a lot between sites, and this is only in one country. You can see that for a similar patient in one site, 5% of the patients received bicarbonate, and in another site, 55% of the patients received, suggesting a heterogeneity in the use of the drug. The predictors for the use of sodium bicarbonate, important that it was strongly related with the bicarbonate and base excess level, but it was not associated with the severity of acidemia, the pH level. And also very important to mention that one of the most important factors associated was the site or the center where the ICU was admitted, suggesting that, and this happens in Australia too, and in several different countries, like in Brazil, where I trained, like the use several times is not dictated by patient characteristics, but by local preferences or local protocols. This is a study that we did in Australia, Japan, and Taiwan. This is in patients fulfilling a less severe acidemia criteria, like a SODa-BIC criteria. Even in this population with less severe acidosis, around 20 to 23% of the patients received sodium bicarbonate. And again, with a huge variation between site and country. Like in one site, only 5% of the patients received. In another site, 78% of the patients received. 10% in Australia, 63% in Taiwan for a same population. Again, suggesting a huge variation. In this study, the predictors for the use were pretty much the same as in the previous study. So patients with more severe disease, they were more likely to receive sodium bicarbonate. With more severe acidemia and acidosis, with higher lactate, or with a more severe shock. In this study, it's an observational retrospective study, but in this study, the sodium bicarbonate was possibly associated with better outcomes in patients with mild acidosis and receiving vasopressors. But again, with all the limitations of a retrospective study. And even the medical specialty might influence the decision to give bicarbonate. This is an old study, but very nice, where clinicians were presented with a case, and you can see that nephrologists, 86% of the nephrologists said that they would give bicarbonate, while only 67% of the intensivists said the same. And this is for the same case. And even the threshold to give bicarbonate was different. Like usually nephrologists were much more liberal and intensivists were much more conservative. So we know that the use of sodium bicarbonate is highly heterogeneous, but that 20 to 40% of the patients will receive at least a dose, and depending on the severity of acidemia and acidosis. And this is mainly driven by local preferences. And what is the evidence? And this was before SODa-BIC. We did a scoping review. We found only 2 clinical trials at the time. The only relevant trial at the time was BICAR-ICU, which was done by Boris and Samir. So it's a multi-center open label trial in 26 ICUs in France, including patients with severe acidemia and with a SOF of at least 4 or a lactate of at least 2, randomized to 4.2% sodium bicarbonate infusions, bolus infusions, to maintain an arterial pH greater than 7.30, or usual care was an open label trial. This trial found that the use of sodium bicarbonate in this population was not associated with a reduction in the primary outcome and also in 28-day mortality. But as you can see, the p-value was 0.09, so a borderline p-value. And in a reanalysis using a Bayesian framework, we found that the potential benefit with this intervention in this trial was 96%. So a very high probability of benefit. They also found that in this population, the use of sodium bicarbonate reduced the use of renal replacement therapy and also delayed the renal replacement therapy initiation by almost 10 days, which is a very important finding. So we have, based on BICAR-ICU, we have data suggesting that sodium bicarbonate potentially improves outcomes in patients with severe acidemia. And in the same trial, the investigators, they did a pre-specified subgroup analysis in patients with acute kidney injury stage 2 or 3. And in this group, they found a significant reduction in mortality with a probability of benefit of 99%. But as we all know, this was like a subgroup analysis with all the risks of having a type 1 error, but it was a very important reduction in mortality in this first study. This was replicated in real-world data. This is just one of the examples using data from MIMIC. So it's a real-world data from Boston. As you can see, patients fulfilling BICAR-ICU criteria in Boston in this hospital, 29% of the patients received a dose of sodium bicarbonate. And in the matched analysis, they found a benefit with the use of sodium bicarbonate in patients with severe acidemia and AKI stage 2 or 3, exactly the same, replicating the findings of the BICAR-ICU. And also they found like a potential benefit in patients with pH less than 7.2 and high lactate, exactly like in BICAR-ICU. So replicating the findings in a real world data. This was also done in Australia, and this is a very nice target trial emulation from colleagues from Queensland. They did like a very robust target trial emulation with a very complex causal inference method. And they found that in a population, even in less sick patients, the use of sodium bicarbonate was associated with a lower mortality and also with a reduction in the use of renal replacement therapy. But they also replicated the findings of the BICAR-ICU, suggesting that in real life, probably bicarbonate also improves outcomes. So the equipoise that we had at the time when we designed the SODa-BIC was even less likely in patients with severe AKI and acute kidney injury. And of course, this was followed by the Surviving Sepsis campaign. I brought here the 2026 update, but if you look at the 2021, the recommendation was exactly the same. So the group recommended against the use of sodium bicarbonate to improve hemodynamics or to reduce vasopressor requirement, but they recommended or they suggested the use of sodium bicarbonate for patients with metabolic acidemia and acute kidney injury stage 2 or 3. And this was based on BICAR-ICU 1 evidence, and this was carried over from the Surviving Sepsis campaign of 2021. And this, of course, was published or finished before the publication of the BICAR-ICU 2. So based on the findings of the BICAR-ICU, Boris and Samir, they did a very nice study, the BICAR-ICU 2, published last year, very similar to the BICAR-ICU 1, but now in more ICUs, and they enrolled more patients. And it was limited by patients only with stage 2 or 3 AKI, which was the group of patients that they found benefit in BICAR-ICU 1. In this trial, there was no difference in mortality with the use of bicarbonate, so it was different from the findings from the subgroup analysis. But again, they reported a reduction in the use of renal replacement therapy with bicarbonate in the sicker population. So in the middle of this time, we started this research program, the SODa-BIC research program. So we did like a pilot to investigate the feasibility of a trial in this less sick population, and of course the feasibility of doing like a blinded trial. So we did a pilot in 30 patients in Australia and New Zealand, 8 sites. We confirmed the feasibility. We confirmed treatment separation, as you can see here, and you see that this will be exactly the same in the phase 3 trial. With only 5 hours of infusion, we used a continuous infusion for 5 hours. With only 5 hours of infusion of sodium bicarbonate, which is the gray area here, we were able to correct the pH, base excess, and bicarbonate levels. It was pretty stable after the stop of the infusion, so we had almost no recurrences. And as you can see, the pH, the bicarbonate levels, and the base excess remained pretty stable after the interruption of the infusion. And it took almost 3 days for patients in the control arm to achieve the same base excess and bicarbonate levels. So we were able, with a 5 hours infusion of the drug, to correct the acidosis, reduce the number of recurrences, and we correct the acidosis faster than in the control arm. This pilot trial was not powered for any detection of important clinical outcomes, but you can see numerically an increase in the hours alive and free of vasopressor-free days with the use of bicarbonate, a numerical reduction in the duration of shock and duration of vasopressors, with a probability of benefit of 92%. But again, this was just a pilot. Because of the pilot, we just proceeded with the phase 3. So the aim of the SODa-BIC trial was to investigate in adults with metabolic acidosis and receiving vasopressor if the use of sodium bicarbonate reduces major adverse kidney event within 30 days compared to placebo. This is the SODa-BIC program. So it started in 2018 when we did a retrospective study investigating the prevalence and the outcomes of patients with less severe acidemia and metabolic acidosis in Australia and New Zealand, followed by a retrospective study investigating the current clinical practice and the use of sodium bicarbonate in this population with less severe acidemia, followed by 2 technical reports where we investigated first the feasibility of double-blinding the solution, which we confirmed to be feasible, and second, to test the stability of the solution to see if the solution would be stable, and the solution that we used is stable for up to 24 hours. Then we did a survey among ANZIC's CTG members asking about the trial, and we used the information of this survey to design the phase 3 and to shape the trial. Then we did a pilot confirming feasibility, treatment separation, and potential benefits, and then we did the phase 3 SODa-BIC trial. In between here, we also did other studies, like we did other surveys investigating change in practice. We also did a study investigating the impact of PCO2, different PCO2 thresholds. So we did other studies as part of the program to help with the trial. So SODa-BIC was an international multi-center investigator-initiated, double-blind, adaptive, randomized clinical trial. The protocol and the statistical analysis plan was published in Critical Care and Resuscitation and is available. We randomized adult patients receiving a continuous infusion of a vasopressor to treat hypotension, with a dedicated line available to infuse the drug, and with a blood gas confirming metabolic acidosis using this criteria. So pH less than 7.3, a base excess equal or less than -4, and a PCO2 equal or less than 45 if the patient was extubated, or equal or less than 50 if the patient was intubated, and this was to allow some degree of mild hypercapnia due to the use of lung protective ventilation. And to be randomized, the patient had to be receiving a continuous infusion of vasopressor at the time of randomization, and we needed a blood gas confirming this eligibility within the last 2 hours before the randomization. Regarding the exclusion criteria, I just highlighted some important one here. So we excluded patients with bicarbonate losses, patients with diabetic ketoacidosis, patients with a eGFR less than 30 due to CKD, chronic kidney disease, patients currently receiving sodium bicarbonate at the moment of randomization, patients currently receiving renal replacement therapy, acute or chronic, or planned to start in the next 3 hours, patients admitted or with an acidosis due to drug overdose or intoxication, patients at risk of cerebral edema and intracranial hypertension because the placebo solution was a hypotonic solution. So we had some exclusion criteria that I highlighted here. Patients were randomized within 2 hours of the blood gas. The randomization was stratified by center, by pH level, and by creatinine level, and both the treating clean and the investigators were blinded. So the placebo was simply a 5% dextrose 500 ml bag, very simple. So the placebo solution was 5% dextrose, and the study drug was prepared by unblinded investigators not involved in patient care, and it was basically sodium bicarbonate diluted in dextrose. So we removed 300 ml of the dextrose solution. We infused 300 ml of the bicarb 8.4%, ended up with a solution of 500 ml with a final concentration of bicarbonate of 600 mg per liter, which were pretty much the same. This is the algorithm that we used. Basically, the algorithm was aiming to keep the pH between 7.30 and 7.35 and the base excess greater than 0. If the pH was greater than 7.35 and the base excess was greater than 0, the infusion was stopped to avoid the risk of alkalosis. If the pH was less than 7.30 or the base excess was less than 0, the infusion was always kept at 100 ml per hour, and the infusion was only decreased to 25 ml if the pH was equal or greater than 7.30 but less than 7.35, and the base excess equal or greater than 0. The infusion was titrated at 1 hour after the start, and at 3 hours after the start, and at 5 hours the infusion was stopped, and then the patients followed with usual care. We developed a decision support tool to help investigators, so it is still available. The investigators will just jump to the site, input here the pH and the base excess, and this would give here the instructions to reduce the number of protocol violations. We had some guidelines suggesting when to use open label bicarbonate, and the infusion should be stopped early based on protocol and based on the usual criteria that we have at the bedside. The primary outcome was a composite of major adverse kidney events within 30 days, which major components were in hospital death, receipt of renal replacement therapy, or persistent renal dysfunction, all censored at hospital discharge on day 30. We had plenty of secondary outcomes, all the components of the primary outcome, renal replacement therapy dependence, ICU mortality, in-hospital death by day 90, some physiological outcomes, recurrence of metabolic acidosis and acute kidney injury in the first 7 days, and some process of care measures, basically vasopressor-free, renal replacement therapy-free, and ICU-free days at day 30, and hospital-free days at day 90. Sample size calculation was based on the information that we had available at the time. So the incidence in the control group was estimated to be 40%, which was informed by our registry. The absolute difference was 14%, which was informed as a conservative estimate from some of the findings of the BICAR-ICU 1, but the trial was also powered to have at least 80% power to detect absolute risk reduction of at least 10% in the composite outcome, and it was powered to have 90% with an alpha of 0.05. We had a sample size re-estimation, a blinded one, after 100 patients were randomized using the aggregate event rate, and following review, the DSMB did not recommend increasing the sample size. So regarding the results, from April 2023 to December 2025, 3,060 patients were assessed. Most of the patients were excluded because they were currently receiving or planning to receive renal replacement therapy, followed by eGFR less than 30 due to CKD, followed by imminent or inevitable death, fulfilled all eligibility criteria greater than 48 hours ago, or followed by acute brain injury or risk of intracranial hypertension. 138 patients were eligible but missed, most of them because there was no personnel available for randomization. So 500 patients were randomized, which 245 were randomized to the sodium bicarbonate, 255 to the placebo. 1 patient in the sodium bicarbonate group and 4 in the placebo did not receive the intervention, and this is because all these 5 patients died between randomization and the start of the intervention. And during follow-up, 2 patients withdrew consent, leaving 498 patients included in the trial. From a baseline perspective, median age was around 65, 68. Most of the patients were males. They were randomized really quickly after the eligibility was met, like 40 minutes. Most of the patients were medical with a median Apache score of 22, which equates a predicted risk of mortality of 40%, with a median SOFA of 7, a pH of 7.26, a base excess of -9, and a bicarb of 17, 18. So even it was a mild acidemia, probably the base excess criteria and the need for vasopressor selected a relatively sick population. The main reason for the metabolic acidosis was sepsis or septic shock, followed by cardiogenic shock and followed by hypovolemia and cardiac arrest. The median creatinine was 129 micromoles per deciliter with a lactate of 2.5. Around 45% of the patients had AKI and 80% were on mechanical ventilation. So that the average patient enrolled in SODa-BIC was a male patient around 65 years old, admitted due to a medical reason with septic shock and usually on 0.15 mics per kilo per minute of noradrenaline and on mechanical ventilation. This is not important for us at the moment, but just from an Australia perspective, this is just to show that this population represented a sicker population than the usual patients in Australian ICUs. But important thing to mention is that we had a good indigenous representation in this trial. So most of the patients received the infusion within an hour of randomization, which was the aim, received the infusion for a median of 5 hours, 500 ml of drug was infused. The total bicarbonate dose used in the interventional arm was 300 millimoles, which is a high dose. It's important this when we compare to the other trials. The total dose was similar, sometimes even higher than in BICAR-ICU and BICAR-ICU. Most of the patients, had the study drug titrated, especially in the sodium bicarbonate group. And the use of open label bicarbonate was 7% in the sodium bicarbonate group and 15% in placebo. You can see that this graph mimics exactly the pilot graph. So we were able to correct the acidemia very quickly with the use of bicarbonate, and it was pretty stable after we stopped the infusion. And again, it took much longer for the patients in the control arm to have their base excess levels and bicarbonate levels corrected. And even if we follow these patients for 7 days, you can see a sustained treatment separation even after day 5 or day 6 with a higher levels of pH, bicarbonate, and base excess in the interventional arm, even with a shorter infusion of only 5 hours. So we achieved a very good treatment separation. Regarding the use of open label bicarbonate and recurrence of acidosis, you can see that persistently over the 7 days, the percentage of patients with recurrence of acidosis was much lower in the sodium bicarbonate arm compared with placebo, which was the red line here. And the use of open label bicarbonate was also much lower in the sodium bicarbonate group compared with the placebo group, again confirming a treatment separation and confirming that the intervention treated our patients. The drug was interrupted earlier more often in the sodium bicarbonate group, and this was mainly due to the interruption based on the protocol when patients had a pH greater than 7.35 and a base excess greater than 0, and all the other reasons for the interruptions were similar between the groups. Regarding the follow-up and other important pathology tests, you can see that consistently patients randomized to sodium bicarbonate, they had a higher PCO2 level, but it's still within the normal limits, less than 45. Higher levels of sodium, but again, within the normal limits, less than 145. Lower levels of potassium, but it's still within the normal limits, so greater than 3.5, and there was no difference in creatinine levels over time. Regarding the primary outcome, the incidence of major adverse kidney events was 40% in the sodium bicarbonate group, and it was 39% in the placebo group with no difference between the groups. And as you can see, we achieved exactly the incidence that we were expecting based on the sample size calculation, excluding major effect with the use of bicarbonate. In hospital death was 25% in the sodium bicarbonate and 24% in the placebo, again, with no difference between the groups. Renal replacement therapy was 17% in the sodium bicarb and 21% in the placebo, again, with no difference, but with a wide confidence interval, suggesting potentially some benefit. And in the persistent renal dysfunction was 14% in the sodium bicarbonate and 18% without difference in the groups. Important to mention that the median time from randomization to initiation of renal replacement therapy was very similar between the groups, suggesting that if there is any effect of bicarbonate that was not detected in this trial because we are not powered, they were not because the decision-making was delayed. This is probably because some patient dialysis was avoided in some patients, in fact. These findings were confirmed in all sensitivity analysis, confirming the robustness of the findings, and they were also confirmed in all subgroups. There was no heterogeneity of treatment effect. The only effect that suggested some heterogeneity was in the patients with AKI, where the use of bicarbonate was associated with a reduction in MAKE 30, and this was with a p-value of 0.08. When we check only the patients with AKI stage 2 or 3, you can see that the major impact of sodium bicarbonate was in reducing mortality and reducing the incidence of persistent renal dysfunction, but not reducing much the use of renal replacement therapy. Again, this is just a subgroup analysis with a lot of problems, but important to discuss. There was no difference in any other of the secondary outcomes, so the renal replacement therapy dependence was similar between the groups. ICU and in-hospital mortality at day 90 were also similar. The recurrence of metabolic acidosis was lower in patients randomized to sodium bicarbonate, but the incidence of AKI and its severity was also similar between the groups. And finally, for the process of care measures, they were also similar. There was no difference in vasopressor-free days, renal replacement-free days, ICU-free days, or hospital-free days at day 90. Regarding adverse events, they were very rare. There was only 4 patients in the sodium bicarbonate group, and they were all due to hypokalemia needing correction during the infusion of the drug, which is something that is expected when you use sodium bicarbonate. This is just a health economic analysis and a cost effectiveness analysis. You can see there was no major differences between the groups. The only thing is that we found a dominant effect when we assessed the receipt of renal replacement therapy with a potential reduction, which was not statistically significant. And as you know, in Australia, this treatment cost $25, and 1 day of renal replacement therapy cost $1,300. So if this is confirmed, it's potentially cost saving. So in conclusion, in this trial, we found that in critically ill patients with metabolic acidosis and receiving vasopressors to treat hypotension, sodium bicarbonate therapy did not reduce major adverse kidney events within 30 days compared to placebo. And just before I close, I just want to highlight Rinaldo, who was an instrumental part of this research program since we started in 2018. Unfortunately, Rinaldo passed away last year, but he was very enthusiastic about this research program. Just want to quickly mention that we recently published a viewpoint in critical care and resuscitation where I discussed the findings of the SODa-BIC, and I tried to put into context with the literature. It's a very nice, just 2 pages, a view from the author. So it's a nice paper to read. And the paper is also published in the New England and is available, and very happy to discuss with you. So thank you very much again.
Thank you very much, Ary. Congratulations on this study, and thank you very much for this great presentation. First, I would like to ask Professor Jung for an assessment and some few comments on your presentation.
Thank you. Thank you again for the invitation, and congratulations, Ary, for this amazing program. Not only a study, but a program that started many years ago with several studies, as you highlighted. I would say that, again, this is a very nice program that combines epidemiology, feasibility, pharmacology, a pilot study, and then a large randomized clinical trial that have evaluated hypertonic sodium bicarbonate in a population presenting with moderate acidosis and shock. The intervention was short, 5 hours of administration of either sodium bicarbonate or placebo, which is, again, very clever to have designed a double-blind study in this population, because we all know that every physician has to assess the pH with blood gas. But anyway, it was because it was a short amount of time and a continuous infusion. My understanding is that the blinding was real and very, again, interesting and smart. The primary outcome was not significant between the 2 populations, but there are some interesting signals, especially in the sickest patient, pH of 7.10 or less. There is if I remember well your paper, Ary, in the supplemental, there is a signal towards less mortality in patients with a very low pH receiving sodium bicarbonate versus placebo. There is also a trend for patients with AKI, favoring the administration of sodium bicarbonate in this subpopulation. Kidney replacement therapies was infrequent in your study, 15 to 20% in the overall population. But again, because I guess that only 25 to 30% of the population had AKI. I think it's 100 patients approximately had AKI. So this is expected that the use of kidney replacement therapy is infrequent in the overall population. I would like to ask you one or two questions because I'm very curious and excited about your study, especially about some subgroups. We studied like pH of 720 or less and patients with AKI. Have you looked at this very specific subpopulation combining severe acidosis with a threshold of 720 and moderate to severe AKI? And that's my first question. And my second question is, I don't remember exactly if kidney replacement therapy indications were standardized among the centers or not.
Amazing. No, perfect questions, Boris, and thank you very much for your comment. I think like this program was definitely inspired by what you and Samir and your team and friends did over the last years. I think like BICAR-ICU, and I was still in Brazil, changed practice in Brazil, like and raised a lot of discussion. So I think it was very important trial, and now BICAR-ICU too is also an amazing trial. So first, congratulations with your research program too. It was definitely inspired by your work. I think like the severity is a very good question. No, we did not investigate using exactly 7.20, but we have a sub study that we are doing at the moment where we are investigating the impact of the severity of the acidemia at baseline or at randomization and the effect on treatment effect. So to see if the severity influences the treatment effect of the trial. So we have this underway. We are performing this analysis now because I agree with you that there is some signal suggesting that in sicker patients, like probably the treatment effect is bigger. So it's something that we are investigating. And regarding the renal replacement therapy, you are 100% correct that we did not standardize, which is a limitation and is a criticism. And the reason, so we have some reasons. So the first reason is that our experience in Australia, and not much more Rinaldo than my experience, Rinaldo like knew everything about research in Australia, was that it would be really hard to I will use the word force. It's not force, but like convince clinicians to follow like a predefined rule to start renal replacement therapy. We would probably fail. So this was one of the reasons. So first we said it will be difficult. It will not be applicable, understanding that this is a limitation. And the second is like we wanted to leave clinicians free to initiate renal replacement therapy according to their preference, understanding that this would affect both groups in the same way. And now what we are doing also a sub-study investigating indications. So we are getting data for all the patients who received renal replacement therapy. We are getting like a lot of information, like indication when it's possible to infer from the data and from the discussions with the clinicians. So indication, the last blood gas before renal replacement therapy, blood test, X-ray, fluid balance, to investigate if the use of bicarbonate changed the practice, like the way that or the reason for renal replacement therapy, or if it was pretty much the same. So, but it is indeed definitely a limitation that we did not standardize the use or the criteria to start renal replacement therapy in the trial.
Thank you so much. I do not have any other questions, but I'm happy to interact with all of you if you have any comments or questions.
So maybe I would start some questions from my side. So I think you showed in your slides before that the total hydrogen carbonate dosage was 300 millimole. What was the rationale for the setting for this specific dosage? So why you choose 300 or not 200 or 400? What was the pathophysiology behind this?
Yeah, very, very good question. And I think this is related with the idea of trying to do a double-blind trial. It would be really hard to blind a trial where you need to do repeated infusions of sodium bicarbonate. There is no, at least in Australia, no interest from the company to produce like placebo bottles because it's very cheap. And so we decided that we will try initially to do an infusion. We said, okay, let's do an infusion. It's easy to prepare. It's easy to blind. And then we discussed the infusion period. And then some clinicians and some researchers said we need to infuse for at least 24 hours. Some other clinicians said we need to infuse until the vasopressor is on. Some said we need to infuse for a longer period. So it was a lot of discussions. And then we, using the data from the BICAR-ICU one, which was the trial available, there is like we were able to estimate the amount of bicarbonate used during the period that the study, I think was 28 days, right, Boris, of like use. And then we estimated the total number of doses used, and we calculated and said, okay, let's try to achieve that dose over a period of time and a bit more, just to be 100% sure that we will give enough bicarbonate for this population, which is less sick than in BICAR-ICU. So the 300 was like similar, it was around 60 millimoles per hour, per 6 millimoles per hour, which was usually the initial idea. And then we did the pilot and we confirmed that we were able to achieve the treatment separation and to sustain the effects after the infusion period. And this is how we end up with this infusion. Of course, there is the thing of like, if we are able, and we are open to change after the pilot trial, but again, as this is a blinded trial with no industry support, we said if we are able to show that with just one bag, we are able to achieve treatment separation and of course sustained separation, this is probably the most convenient for the nurses and for the teams. And as we were able to show, we decided, okay, so we have some rationale because it's similar and a bit more from the BICAR-ICU amount of drug used. We are able to achieve treatment separation. We are able to achieve like a sustained effect. So, and this is why we decided to, but there is no magical rule like, oh, we think that this is the right number. It was just like all these steps, like acknowledging that this is also a limitation, like a lot of, if we continue for a longer period or if we repeated the infusion, results might have been different. Yeah, but it was not the initial objective of the trial.
And another question, I think it's a discussion Gunnar and I, as nephrologists, we talk a lot about here in the ICU, because the ICU physicians usually say, oh, if the pH is better balanced, the vasopressors are more effective. And I think in your study, does your study refute this theory? Because we see that the vasopressor free days are usually the same.
Yeah. I think like it's a very good point, Karen. And I think this is again another sub-study that we are doing. We are doing a hemodynamic sub-study where we want to investigate this impact on vasopressor a bit more like in deeper, like because as you know, vasopressor-free days is a combination of duration of vasopressor, but also mortality. And all patients who died received 0 vasopressor-free days. So we don't know if this masked any effect on duration of ventilation or duration of vasopressor per se. So we have the data of the duration of vasopressor, but we are collecting more data like change in blood pressure in cardiac output were monitored, like CVP and other stuff. And our plan is to do a deeper like investigation in this. If we will be able to find anything, I don't know, but definitely duration of vasopressor is different from vasopressor-free days. This is why we want to do this study. I think like there is a study, and one of our investigators, Jamie Cooper here, it's a very senior clinician and very senior investigator here in Australia. He did years ago, I think was in, if not in the 90s, was like early 2000, where he did like a small trial in lactic acidosis using sodium bicarbonate, trying to show the impact of bicarbonate on hemodynamics and vasopressors dependence, and he did not find any effect. And he was like, after my presentation, of course, he's part of the trial, he said, look, Ary, I think now is enough. We were able at least to show that from a vasopressor perspective, probably sodium bicarbonate doesn't make any difference. But of course, acknowledging that it may be in a sicker population, as Boris said, maybe if you have a patient much more sick, like with like much higher dose of vasopressor and much more like lower pH level or less or lower like base excess levels in this population, I don't know, maybe it helps. The trial was not designed to answer that question. So, but what we have at the moment is that in this less sick population, where the use of vasopressor was on a dose of 0.15 micrograms per kilo per minute, which is not a very high dose, it did not affect vasopressor-free days. And let's see if there's any effect on duration of ventilation. But again, I think it does not rule out that in sicker patients with much more vasopressor and lower levels of pH might have an effect.
And maybe one last question from my side, because we also sometimes see patients in ICU with a metabolic acidosis and the natrium level is still high. So then there comes the discussion to trometamol tris buffer. I don't know if it's common or used in Australia or in France. Do you have some experience, or what do you think about this?
Do you want to start, Boris?
Well, I would say that it's no more available in France, and it's not been available for years now in France. And I don't have any experience of that.
Yeah, same here. Like I don't even know if it's available, but don't have any experience and I've never seen. The only thing is slightly different that at least in Australia, I don't know how it's in France at the moment, or we have more common. It's becoming more common. Is isotonic bicarb. It's becoming like I see, especially the young registrars and the consultants, they start to use a bit more liberal like isotonic bicarb than it was during my time when I was doing my training. But it's the only thing, like still bicarbonate, but just an isotonic infusion.
And yeah, absolutely. And I would say that the BICAR-ICU 1, 2, and the SODa-BIC trials have shown that in most of the patients, even in the sickest patient, sodium bicarbonate infusion is safe. There is no large side effects. It's safe. When I trained, there was some controversies about sodium bicarbonate being dangerous for patients because of paradoxical acidemia, alteration in oxygen transport, and so on, with some experimental studies that indeed show that there might be some side effects, but other experimental studies are showing exactly the opposite. So we and Ary have shown that for most of the patients, it's really safe. And I would say that one way of being even safer is to infuse slowly, not as a bolus.
Yeah, I agree 100% with Boris there. Yeah.
Since we have these alternatives here in Germany, would there be any pathophysiological idea that switching to another buffer would make more sense, or would it just be with regard to safety, as you just explained to us, Boris?
I don't know about a better pathophysiological pathway that would promote the other buffer. My way of understanding the mechanism is that in some patients, it delay or avoid kidney replacement therapy. It buys you time to stabilize the patient, resuscitate it well, give antibiotics, maybe surgery. So I'm not sure about really a difference in pathophysiology. Ary, what do you think?
Yeah, I agree 100%. I don't know, as I said, I don't have much experience, but I agree with Boris that it's not about normalizing the pH. It's about buying time and avoid clinicians of starting something that is probably bad for our patients, as Boris said. And then like instead of like in Australia, like it's changing now, but I was very liberal with renal replacement therapy. And we have now data suggesting that a lot of data from France, very nice data from France, suggesting that we might wait a bit and see. And giving bicarbonate would be another way maybe to hold clinicians to say, okay, I'm more comfortable now in not starting renal replacement therapy, and then give you time to do something else and protect the patient from receiving renal replacement therapy, like if it's not truly necessary. So I cannot think of any other like specific pathophysiology that would be different compared to sodium bicarbonate.
To our best understanding, there's one trial still going on, I guess, in the UK, the Mosaic trial, which will add further data in this field. In how far might this supplement the results from Australia and from France?
No, yeah, Mosaic, Paul Mounsey and Louis Forney, they are running this trial. It's a combination of SODa-BIC with BICAR-ICU 2 because it's a less severe acidemia than BICAR-ICU 2, 7.3 as we did in SODa-BIC, but only in patients with stage 2 or 3 AKI. So it would be a good combination. It would be also slightly different because it will be like less sick, but with AKI, which will be good. And as we found in SODa-BIC, maybe a signal in patients stage 2 or 3 AKI. So Mosaic will come and answer this question. They are recruiting better than they were at the beginning. So it's a very large, they're planning to do a very large trial. So it'll be the largest trial. So it'll be amazing to see the results. We have some already discussed with Boris and Samir and also Paul that we might be able to combine this data in the future to do a very large individual patient data meta-analysis, and then we'll have power to investigate a lot of subgroups and different populations and do very nice analysis, I think.
I have two final questions. The first would be, surely all your studies excluded some subgroup of patients, particularly patients with diabetic ketoacidosis and patients who have just been resuscitated. But seeing all these three trials being negative, at least with regard to the primary endpoint, have you become more conservative with bicarbonate treatment also in people with diabetic ketoacidosis and people after resuscitation? Or would you say with this this is a completely different field, and one should not transfer the data from BICAR-ICU, BICAR-ICU2, and SODa-BIC to these people?
So I would say that in patients with diabetic ketoacidosis, the current guidelines suggest not to use sodium bicarbonate unless pH is really low, 6.9 or lower. There's not been any evidence suggesting any benefit of sodium bicarbonate in this population. And we will publish the French guidelines on diabetic complications in the ICU at the end of the year. We just had the conference done, and the results were presented at the French Annual Congress of Critical Care Medicine in June. And we will go even further, saying that there is no room for sodium bicarbonate in DKA, regardless of the pH. So that's the French way of analyzing this population. And so I believe that there is no equipoise of giving sodium bicarbonate in this very specific population.
Yeah, I agree 100%. I think it's pretty much the same our practice here. Like our guideline, or not necessarily the guideline, our local protocol says that to restrict to very sick patients with very low pH. In my practice, for example, I cannot remember the last time that I gave like a DKA patient bicarbonate. So I would not definitely not considering this population. So not translating the evidence from BICAR-ICU or SODa-BIC, because I don't think we can, it's different population, but because I don't think it's necessary, and it's not, we don't have any evidence to support it too.
And patients after resuscitation?
After resuscitation with sodium bicarbonate or with something else?
Yeah.
Well, we did not consider enrolling these patients to avoid any confounding bias. But in my practice, if a patient already receives sodium bicarbonate in the emergency department, for instance, well, I would give him more sodium bicarbonate if he has any reasons to receive sodium bicarbonate.
Yeah, exactly. Agree.
And my last question for clinicians, reading the 3 papers again, all of which have a negative primary outcome, but at least 2 of the 3 suggesting that there might be subgroups that may benefit nonetheless. And we all know that we should not really trust too much on subgroup analysis, but we have to find solutions for our patients. So having read, with regard to you, having done all these studies, which subgroup of patients would you in clinical practice now in summer, autumn of 2026 still consider to receive bicarbonate?
You want to start, Boris, because we started first? Yeah.
Okay.
You did all these studies first. Yeah.
Okay.
Yeah, you can start. Yeah, you can start. Yeah.
In 2026, at the bedside, my practice is to give sodium bicarbonate quite liberally in patients with metabolic acidosis. And when they are either presenting with AKI or who needs fluid resuscitation, so metabolic acidosis with either fluid dependency or AKI and no contraindications. And in these patients, if they are moderately acidemic, I use isotonic sodium bicarbonate. And if they are severely acidemic, I use hypertonic sodium bicarbonate. But when I use hypertonic sodium bicarbonate, I always check first ionized calcium level, and I would increase the ionized calcium level if it's low. I would make sure that serum potassium is not low, and I would infuse sodium bicarbonate slowly, like over an hour or 2 hours, and that's my practice. So I use it quite liberally at this time.
Yeah. I think the only difference for me is like I tend to be more restrictive than SODa-BIC. Though SODa-BIC, despite being the PI of this study, like I'm not very, especially now with the findings, like I'm not giving bicarbonate just because patients have like a pH less than 7.3 or something like that. I consider more now, especially in patients with AKI, where acidemia or acidosis is something that is of concern, especially for clinicians or nurses. They're really concerned and considering starting renal replacement therapy because the creatinine is not good, it's increasing, and the patient is more acidemic and acidotic. So this is the population that I usually would try to give a bit of bicarbonate, because I think this is the population that we might reduce the need of renal replacement therapy. I do the same, like I usually use a slow infusion, not necessarily the SODa-BIC infusion sometimes, but not necessarily the same algorithm, but I use a slow infusion. And with the isotonic bicarbonate, it's like, as this was never investigated, but as I said, I'm seeing more, and I'm been a bit more liberal in the initial phase of resuscitation if the patient presents with severe acidosis and it is needing fluid. So I think I'm less liberal than SODa-BIC, but I was a bit more liberal than I used to be in the past, where we did not have any evidence.
So thank you very much. After we already covered renal acidosis by Marcus at home in the past, now we come full circle with the discussion of metabolic acidosis in critical ill patients today. Thank you very much for joining us from Melbourne and from Montpellier in France. And I hopefully maybe we will see you back here with some subgroup analyses. And I think that there's a lot to come in future. And thank you very much. And hopefully we'll see you again here by Marcus at home.
Thank you so much.
Thank you very much. A pleasure to join and participate.